Hey everybody, welcome. This is Jason Clemens, Doctor of Chiropractic at the Rock Health and Wellness Center, and this is Life with Jason Clemens, DC. We are live right here at the Rock Health and Wellness Center studios in Lubbock. We're live on the radio at 98.7 Walk by Faith, 1420 AM. We're streaming on 987radio.com, and we are live on our social media. The Rock Health and Wellness Center is on Facebook, at Health from the Rock on YouTube, and Jason Clemens, DC on X. Hope everybody had a great week. We sure had a great week at The Rock. Just like another great week in a row. I think it's like 20 years in a row of great weeks. And I was listening to we're getting some new technology in the building. I'm not quite ready to let the cat out of the bag on that one. I'll probably will next week. But I was listening to a video of a guy, and he said he's in his 31st year of practice, and he's just excited as he's ever been, and he just feels like he's getting started right now. And I just started laughing. I was like, amen. He's in Chicago, and he was telling that story in the video I was watching, and I was like, yep. It's like, it takes 20-something years or something to feel like you're finally getting some traction. You're kind of moving in the right direction. Like you might have learned something over this period of time. And so I'm hoping that maybe what we're bringing to you on this show is helping you. Maybe you close the gap. Maybe you don't have to wait 20 years before you learn something about health. And a lot of you guys know a lot about health, and a lot of you guys know a lot more than I do about health. So, but maybe it'll help just a little bit somewhere. You can pick up something. At least we try to bring it to you. And what we do bring to you is clinical stuff that's coming to you right straight out of the office, right? I'm seeing patients, and then I'm coming in here and I'm doing a show, and we're talking about that stuff. And so I try to surround myself with guys that are pretty passionate about health, that are pretty passionate about studying. And it's not anything new to us. With the invention of Instagram and all the social media, you've got a bunch of people that are on there, and some of them are doing fabulous jobs with their shows and their podcasts and all that stuff. But this journey for me started 25 years ago. It actually started further than that, because it started when I was 17, getting my first adjustment, and then being exposed to my brother-in-law, who was a chiropractor, and watching things take place. But I did go to work for him 25 years ago in March of 2000. And so these conversations that we have on the radio, a lot of these conversations I had 25 years ago. So I've had a long time to metabolize some of this stuff. And I've had a long time to think about it, and then discard it, and then ignore it, and then bring it back in, and then work through it, and then throw it away again. It's like it's been a journey so far to absorb some of this information. So when we go over these articles and we talk about the things that we talk about on the show, then just know that it's taken me a long time to absorb it. And I hope you can absorb it faster. That's really the whole point of what we're doing. So, hey, if you got any questions, comments, you want to send it to me, 806-794-0400. You can send me a text. You can send me a message on social media. You can send me a criticism, like whatever. If you got anything you want to send me, you're welcome to send it to me, and we'll address it. And we'll address some of it tonight too, if you want to. If you got a topic or something that you would like to talk about on the show, you can send me that too. And I'll try to address whatever topics. I'm really excited about some of the stuff that's happening at The Rock. I'm really excited about the things that we've put together. It seems like every year we get another piece. We get another piece of the picture. We get another tool that we can use. I'm really excited about some of the tools that we have. The neurofeedback stuff that we have is really, I think, going to be impactful when we really get that to you. And then this stuff that we're just about to offer is going to be impactful. So I'll make a decision on it this weekend, and then I'll be able to talk about it. So let's get back into talking what we were over the last couple of days. We've been talking about we've been talking about chemistry and fuel and activation and how it affects our bodies, right? And we use fish oil to as the subject to explain it, just because it's easy, or I don't know, it's very abundant in research about how the chemistry changes with the EPA and the DHA in your fish oils, right? You look on the back of that bottle and you see that EPA and you see that DHA, you get into the chemistry changes. And so last night we talked a little bit about movement and how movement works. Well, so tonight what I want to do is I want to finish one article that was on my mind from a couple days ago, just because there's a point or two in the article that I want you to know about. And then I want to talk about spinal movement and the brain, because you may not have that connection made together. Spinal movement and the brain. How does spinal movement affect what's going on in your brain? And there's some really interesting studies that were done. There was the one in 2017, and it's kind of an offshoot of another one that was done in 2011. And so both of those studies together are ones that I are kind of cool, really, about showing like actual spinal adjusting and the way that it changes like glucose levels in the brain. So we'll get into that. We'll get into that in just a second. But first, I want to go over this one article that I didn't really get to in the last couple of segments. And this comes from this. It's called Analgesic Effects of Non-Surgical and Non-Interventional Treatments for Low Back Pain, a systemic review and meta-analysis of placebo-controlled randomized trials. British Medical Journal, Evidence-Based Medicine, March 18th, 2025. And be very careful when you hear that term, evidence-based medicine. That's mostly hogwash, but they may be trying, but there's a lot of smoke and mirrors when you get into that stuff. But there's a whole group of people right here that did this article from University of New South Wales in Australia, Memorial University in Newfoundland, Canada, University of Sydney in Australia, Science Integrity Alliance USA, Federal University, bunch of stuff, like bunch of smart people put this thing together. The objective of the study was to investigate the efficacy of non-surgical treatments for adults with low back pain compared to placebo. The authors found that evidence for non-surgical treatment of low back pain is of low or very low quality. They're trying to find the evidence, right? A total of 301 trials provided data on 56 different treatments or treatment combinations. The authors included published randomized placebo-controlled trials of non-surgical treatments for people with non-specific low back pain. Now, they excluded a bunch of stuff. They excluded studies on the subject of specific spinal pathologies causing low back pain, including like infection, cancer, vertebral fracture, spondylolysis, inflammatory disease, which some of these I wish they wouldn't have, spinal stenosis, pregnancy, recent spinal surgeries, lumbar radicular syndromes, like if you got pressure on your nerve running down your leg or any of that sort of thing. Trials were conducted in 6 continents, 44 countries. Pain intensity was assessed with the Visual Analog Scale, VAS, and the Numeric Rating Scale. This is the most comprehensive systematic review of placebo-controlled randomized trials investigating non-surgical and non-interventional treatments for non-specific low back pain. So, what did they find? Of course, low back pain is common and burdensome problem characterized by debilitating pain, impaired function, societal withdrawal, and financial impact. That's a big deal right there if you really think about it. I know that happened in my life. In my house, it happened. Uh, my dad's spinal disease, if you want to call it that, affected his social interaction with people. He was embarrassed by the way he looked. He was embarrassed by the way he moved. His brain didn't work properly, and it changed the interaction he had with other people. So I know that for a fact that low back pain is a common and burdensome problem characterized by debilitating pain. Yep, he dealt with that. Impaired function, absolutely impaired function spinally and impaired function in his brain, and societal withdrawal and financial impacts. All those things were part of my life growing up. So I know for a fact that that's true. And if you are dealing with back pain, or your family's dealing with back pain, or somebody in your family is dealing with back pain, you're probably dealing with a lot of those same things too. Now, I don't. I'm not a back pain guy, but I do have passion for or compassion for people that have back pain, and we do try to get rid of it as quickly as possible, and then we try to be well after that, right? So, the majority, 80 to 90% of low back pain is categorized as nonspecific based on the fact that a nociceptive cause cannot be reliably identified clinically. And Dr. Murphy said that's an important factor right there. A nociceptive cause, the chemistry receptor can't be found in the whole, can't be reliably identified clinically. And one of the things I learned back about 2000 when I went to work for my brother-in-law is I was reading a book and I got exposed to Barry Sears and the zone diet. And I got exposed to the word eicosanoid. And if you want to go back and listen to Barry Sears talk about an eicosanoid, I've mentioned it, I think, on the show in the past. But an eicosanoid is like a little chemical that's released by a cell. So it's a way that the cells can communicate with each other. So if you got a cell over here, and you got a cell over here, and you have a cell over here, and then you got that interstitial fluid, that matrix all between that tissue that's all in between those cells, right? Then, remember we talked about in the brain with the end of Alzheimer's, we talked about the receptors that were detecting the environment around the cell, right? So think of it that same way. You got these little receptors that are on this cell, and they're just kind of like antennas around the cell, and they're just detecting what's happening. It's kind of like your thermostat, right? It's a little hot in this building tonight because the air conditioner's not set properly. And so you've got a cell, and that cell's got a receptor, and that receptor's kind of it's detecting the environment around it. Okay, so here's the chemistry part. And here's the part that when we talk about this is a brand new article that just came out, British Medical Journal, and they're going through all these randomly controlled clinical trials, and that's why I'm trying to say evidence-based medicine is at times it's a bunch of ignorant people that think they're smart. And you guys know that who these, like, you've met people like this before. Like, you've met young, college-educated, or college-trapped. Maybe they're not young anymore. Maybe they've been in the college bubble forever. These people that think they know everything there is to know about everything, and then in real life, they really don't. It's not really the way it works. And then somebody that is off the street comes along and just takes them to the cleaners, just wham, just like shows them how it's done. That same thing happened in football with a guy named Mike Leach. He changed. You guys, anybody that follows football would understand that. From the beginning of football time until Mike Leach showed up, the philosophy and the belief system of how you were supposed to coach a football team and how you were supposed to run a program and how you were supposed to do plays and all that sort of thing fit in a little bubble that was about this big around. Barry Switzer kind of changed it a little bit with the wishbone, and then June Jones came along through the football a little bit, but there was like this whole time, and then all of a sudden Mike Leach came along and he just did it different. And you know what? He didn't play college football. He was an attorney from Pepperdine, I believe. Like he hung out with the guy Lavelle Edwards out of BYU and learned some stuff. He was a good coach. I mean, he was a coach for no question about it. But the way that he looked at it was just different. And now you make the mark from when Coach Leach came on the scene until now, he's changed the entire game of football from Little League all the way to the pros. His impact is unbelievable about how it happened. And my point is, you had this group of guys that think this is the way it is, and they'll sell you crap like evidence-based medicine. But because how are you going to evidence? And this is let me get back to this point here, and I'll show you what I mean by that. This environment that's being detected. Now, all of a sudden, the chemistry comes along, and you eat an omega-6. You eat your peanut butter and your corn chips, right? So you're going to eat your peanut butter and your corn chips, and then I'll make those so you can see them. There's going to be some sort of identifying this environment. This is going to be in there in some form or fashion, because you had a blood vessel, and that blood vessel was running past all those cells, and these omega-6s were inside that blood vessel, and they leaked through the blood vessel, and now they're in the tissue. And so now the tissue is determining, okay, there's an omega-6 right there. It's like, boom, that connects to that, and now the cell realizes that the external environment has high omega-6s in it. And now we're going to go through this biochemical reaction, and what we're going to end up with is we're going to end up with an eicosanoid. I think it may be EICOS, INOID. I don't know how you spell it. EICOS, I think, eicosanoid. It's a puff. It's a puff right there. It's like a 9-second chemical smoke signal. It's like the old days where you're watching the Cowboy and Indian show, and then they're giving the smoke signals from one to the place to the next, right? You're going to get an inflammatory eicosanoid that's going to puff out, and it's going to ask, it's basically one cell asking another cell, hey, what'd you get? And this cell over here is going to have this eicosanoid, and it's inflammatory, and it's going to puff out. And then that's going to puff to this one, and that's going to puff to that one. And those cells are communicating with each other with this eicosanoid that lasts for about 9 seconds. And it's really, you can't really measure it in a blood test because it's gone. It's just like, it's just like this word is gone. If we didn't record it, you can't hear it. You can't run it back. If we have, what'd you say? I didn't hear you. It's like, I missed it. It's like, I wasn't recording it, right? One cell speaks to another cell. Okay, how do you get a randomly controlled clinical trial if you're having an eicosanoid that's showing that it's inflammatory? Because what's going to happen now, when you get one cell talking to the next cell, which is talking to the next cell, what we're going to get is we're going to get expression of inflammation. That's what we're going to get. We're going to get an expression of inflammation. Now, you could do this same exact model, and you could do those same cells, and you could do the same receptors all over the cells, and then you could have an omega-3 and an omega-3 that came through that bloodstream. Now you could take your fish oil, and now your omega-3 is what is going to run through and leak through. And now you're going to get a different eicosanoid. You're going to get an eicosanoid that's anti-inflammatory, puffed out, puffed out, communicating with each one of those cells. And now the cells are like, okay, anti-inflammatory expression. And it's like, okay, so what do you get now? You get anti-inflammatory expression. Your body creates chemicals that are anti-inflammatory. Why did it do that? Because it detected inside there. Does that make sense? That's the eicosanoid stuff by Barry Sears. That's the way I understood it anyway. And so you can go back and listen to Barry Sears talk about that in the Zone Diet. I got all the CDs and stuff back in the day, and listen to them. But so you read the sentence right here, and you look at the majority, 80 to 90% of low back pain is categorized as nonspecific based on the fact that nociceptive causes cannot be reliably identified clinically. It's like, is it the disc? Is it the facet? Is it the fascia? What exactly is it? So, because I don't know exactly where the source is coming from, because the source may be intermittent. It may just like be there and then it may be gone, right? Placebo-controlled randomized trials are the best method for evaluating efficacy of treatments. I don't agree with that. It's a great way to do that, but what if you don't? What if you're trying to establish movement? Like listen to Bruce Lipton talk about epigenetics, and listen to the different things. It's like sometimes these placebo-controlled trials are. But I can tell you one thing, they've never done a placebo-controlled randomized trial on 2 medications at the same time. So it's like they don't have it, there's no problem in that realm right there, right? So despite their importance, placebo-controlled trials are uncommon in low back pain research, with most trials compared against another treatment or against usual care. Fair enough. The results, okay? Here they say only one treatment for acute. That means you just hurt yourself. This is not chronic. This is like you just fell off a ladder or you just lifted a refrigerator and you got acute back pain. Only one treatment of acute low back pain was found to be efficacious. Non-steroidal anti-inflammatory drugs. For acute low back pain, there is moderate certainty evidence that NSAIDs are efficacious. Yeah, come on, man. It's like, really? Like, there's nothing else besides NSAIDs. You could try fish oil and turmeric. That'll help, but not in a clinical trial. It won't, apparently. But 5 treatments for chronic low back pain were found to be efficacious. Number 1, exercise. Number 2, spinal manipulative therapy. And that was the point I was trying to make because I'm a chiropractor. Why? I was looking at it, right? Taping, antidepressants, and then this TRPV1 agonist, so for chronic low back pain, there is a moderate certainty evidence that exercise, spinal manipulative therapy, which we call adjusting in chiropractic, taping, antidepressants, and this other thing are helping chronic pain. Now, let's break that down for just a second. Why would an antidepressant help chronic low back pain? Where is pain? Pain's in the brain, right? Pain's not in the back anyway. Pain is in the brain. I think we got that pretty good, but it wouldn't hurt to just review it. Pain is detected in your brain, not in your low back. So you can have a receptor firing in your low back, and that receptor is simply just telling the brain the status of the low back. That's all it's doing. It's running through that nerve. It's going into the spinal cord. It's running up through the nerve. We know it's going like this, but it's firing in there and however it's going. But it's getting up there into that sensory cortex somewhere. But it's also getting down here into this limbic system as well. And it's that symphony of things that's going on up in your head. And it's just reporting. Your low back is reporting, ow. It's reporting the status, into the brain. The brain is processing all of that information, and then it's deciding that this hurts. Pain, ouch, in the brain, right? But, or so, I guess I should say, so antidepressants, which mostly are dealing with this left hemisphere, have the ability to decrease the pain. Well, what do you think a spinal adjustment is doing? Because what most people do, what most people think is they think that the spinal adjustment is somehow taking away the pain in the low back. That's what you think. Oh man, I got adjusted and my back feels better. And it's like what's really interesting is that why your back feels better is because of the changes in your brain by the adjustment. How can you put in the same sentence, how can you put an antidepressant and a spinal adjustment both help chronic low back pain? How can you have exercise help chronic low back pain? What is exercise going to do to help you with it? What is taping going to do to help you with it? Like we run through boxes of rock tape here in the office, and it's a kinesio tape. We do that every day. Just got finished kinesio taping an elbow on a little guy that's going to play, or I don't know, 7th grade or something, that's going to play in a baseball tournament this weekend. What is that tape doing? Is it tape actually changing the function of the elbow, or is that tape changing the nervous system function that's changing the way the brain is firing? You got to stick around. We got to take a break. Stick around with us. We'll be back on the other side of the break. We'll get into how the spinal movement changes the brain. We'll be right back. Yeah, it's pretty cool. I think it's pretty cool that over time, when you really start to study it and you look at it over and over and over again, guns up, by the way. You look at an article like that, and it says those two things. There's just so much depth. There's so much depth. It's kind of like why the Bible is such a living Bible, I think, because you read it one time, and depending on your level of understanding, we've all done that before. It's like where we were in time and space changed the way that we read the Bible. It still happens to me to this day, right? I think that's really what they mean by it's a living Bible. Sometimes you read the same verse and it's like, when did it say that? I don't even remember it saying that. And it's just the way that you saw it, right? So the more we go through these conversations that we have, and the more we talk about the chemistry and the feel and activation and the physical, chemical, and mental emotional stresses and the subluxation and the interference in your nervous system and all that stuff, then you start to read these articles like this, and each sentence has a meaning. Like you could almost do an entire hour show, and so sometimes we do a whole hour show just on one sentence. It's like just this one category. 5 treatments for chronic low back pain were found to be efficacious: exercise, adjusting, taping, antidepressants, and I don't even know what that is, to tell you the honest truth. Transient receptor potential vilanoid. That's the first time I've ever seen that before in my life. I don't even know what that means. But these other things right there, and then if you were to understand the mechanisms of how they worked, then you might understand the mechanisms of why your back is hurting. And this is what I said last night, and I've said it lots of times before. Orthopedic problems happen after brain problems. If your back is you got chronic low back problems, and an antidepressant helps the chronic low back problem, then the chronic low back problem was secondary to your brain. You see what I mean? Like that makes total sense. Hang on one second. Okay, everybody, we're back. This is Life with Jason Clemens, DC, and we're going over some movement and brain stuff tonight. That part of it right there is pretty much the majority of what I wanted to go over in that particular article. Um, they're saying that it's funny in acute low back pain. They're saying that nothing really helped except non-steroidal anti-inflammatory drugs. I haven't really found that over 20 years of chiropractic care, taking care of patients. I haven't really found that to be 100% accurate. I know what they're saying. The reason they're saying that is it's based on the placebo-controlled randomized trials. They looked through 301 trials on 56 different treatments, and then they didn't really come up with that adjustments didn't really fit in that criteria. Well, that's fair. It didn't fit in the criteria, but it doesn't mean that it's not true, because there's thousands and thousands of chiropractors all across the United States and the world that can tell you that that's not true, because we've seen it in our practices for years and years and years and years. It's like people come in with acute pain and they leave with decreased acute pain, and some of the things that we do. So anyway, that's one of them right there. So let's move along and let's go to the next topic, and we're gonna talk about a different concept, and we're gonna kind of follow the same model that we've been following all week. We're gonna take the article, but we're gonna look into it to understand the fuel and activation part of it, right, and the chemistry. So this one is cerebral metabolic changes in men after chiropractic spinal manipulation for neck pain. Let me see. That's the one I wanted to do first. Whoops, 1 second, hang on. Let me see if that was... No, this is the one I want to do first. Hang on 1 second. I need to flip these, because this is the one I wanted to do first right here. This is glucose metabolic changes in the brain and muscles of patients with nonspecific neck pain treated by spinal manipulation therapy. Okay, let me say it again so we can all follow it. This is glucose metabolic changes in the brain and muscles of patients with nonspecific neck pain treated with adjustments, spinal manipulative therapy. Okay, and what they did is really interesting. And of all the articles it's in my least favorite topic: evidence-based complementary and alternative medicine. If you could come up with a title of your article, of your magazine, your publication, that I hate. I mean, you might as well put Texas Longhorns on there somewhere. Evidence-based complementary and alternative medicine. Blah. Okay, but anyway, that's where it came from, volume 2017. All right, this was a group of guys in Japan, and they did a fabulous job with this article. It's a really interesting thing, okay? A whole bunch of guys. The study was done at, I don't even know how to pronounce that, University Graduate School of Medicine in Japan, along with the Division of Cyclotron Nuclear Medicine in Tohoku University. So these guys got into it, right? Well, they use PET scans. It's a powerful neuroimaging technique to investigate neuronal activity in the human brain and muscles. So this PET scan is able to see what's happening in the nerve in the brain, okay? They labeled this 18F labeled FDG fluorodeoxyglucose, I don't even know, is a radioactive analog of glucose and is an excellent imaging marker of brain glucose consumption. Basically, it says if we measure this, then the brain was consuming glucose. That's what they did. And 21 male volunteers were recruited for the present study. The spinal manipulative therapy, and I'm just going to call it adjustment from this point forward, was applied using an activator. Now, that's an important point of this whole thing because patients ask me all the time when I'm using the activator, the little clicker that we have in the office. They ask me all the time, Doc, what's that doing? Is that even doing anything? Right? And so go along with me on this and you'll kind of see what it does. But the adjustment was applied using an activator in accordance with the activator method's protocol. The activator applied impulse to specific vertebrae or joints. So the adjustment was performed on the subjects in a face-down position without movements such as rotation or flexion or extension in order to prevent the muscular FDG uptake due to muscle contractions during the therapeutic procedure. It's really specific. They had these patients laying face down and they didn't want their heads to move in any direction because they didn't want this marker that they're measuring in with the PET scan to be affected by muscle consumption of glucose. So they didn't want the muscles to fire. They just wanted to find the segment and hit it with the activator while the patient was laying face down and still. Okay? So the adjustment was carried out on the whole spine, the scapula, the ilium, and the sacrum as necessary for each subject. The mean number of adjusted sites was 8 per subject. Glucose metabolism of the brain and skeletal muscle was measured. Interesting right there, right? Also measured was salivary amylase levels as an index of autonomic nervous system activity. So we talk about this a lot, right? We talked about the chemistry changing the sympathetic nervous system. We did that on Tuesday, I think. We talked about the chemistry changing your fight or flight response. The diet that we eat, the food that we eat, the chemistry inside of our body can change the autonomic nervous system. Well, this part, because we're kind of focusing on fuel and activation, right? So the fuel that we put in our body has an effect on our autonomic nervous system. And we did shows a couple weeks ago where we talked about increased sympathetic tone or increased sympathetic stress is detrimental to health. Increase right hemisphere firing of your sympathetic nervous system and decrease left hemisphere firing of your parasympathetic nervous system is detrimental to your health. It's bad, okay? So salivary amylase levels is an index of autonomic nervous system activity, muscle tension, and subjective pain intensity. Other measurements indicated relaxation of cervical muscle tension. Decrease in salivary amylase levels is suppression of the sympathetic nerve activity. So by measuring that one thing, they were able to measure the depression of the sympathetic nerve activity and pain relief after that, okay? So it was done by a chiropractor. They went through the thing, tells how they did it. We observed multiple changes in brain activity after the adjustment. We have a guy named Christopher Kent in chiropractic, and he was working at the World Health Organization or somewhere. He was working with a whole group of doctors that were measuring brain activity in the scans. I don't know, some sort of functional MRI or something like that, scan technology that they were doing. And he waited till the very end of the weekend or the week that he was working with them, and he just was there and working with them. But he didn't say anything about chiropractic or the chiropractic adjustment. And he just asked them, he said, it would just be, if we have an extra minute, if we have just a few more minutes at the end of this, when this is all over, could we just measure one thing just once, just so I could show you guys what's happening? And they were like, sure, okay. Because most of them were medical doctors in the group. But Christopher Kent, he's one of the top researcher guys that's been in chiropractic my whole career, really at the top of the chain as far as working with a lot of different disciplines. And he adjusted the toe. He put the patient in the machine, whatever they were measuring, and he just adjusted the big toe, and the brain lit up. The brain lit up with the adjustment of the big toe, and then that was it. And they all just kind of looked at each other. They were like, he tells a story. And he's like, they just kind of looked around. They didn't know what to say. They're like, well, okay. And then they just went on with it. They just left it and finished their little thing. But it just planted a little bit of a seed right there, right? So when I hear this sentence, we observed multiple changes in brain activity after the adjustment. I know that's factual. That's why when people talk to me after 25 years of being in this and after 34 years or whatever of getting adjusted, it's like the naysayers of chiropractic. Those people, they just don't understand. It's like I can't show it to you. That's the hard part. It's not like cutting the grass or fixing the flower bed. After I work on that all day long, you can be like, oh man, that looks beautiful. After we work on an adjustment, you leave here and it's like, well, I don't know. Did anything even happen? And it's like, yes, it happened, right? The findings of the present study demonstrated how stimuli to the mechanoreceptors of the joints of the skin, mechanoreceptors of the joints and skin during adjustments are processed in the brain. So you're set up on a person and you're moving that person into position about how you're going to adjust them, right? You're going to put them in the proper position. Just the setting up by itself is altering the brain, is affecting the brain. Just the fact that I touched you is right there. The findings of the present study demonstrated how stimuli to the mechanoreceptors of the joints and skin during the adjustment process are processed in the brain. Just the fact that we touch the skin, if we were doing a PET scan, it would light up. And then all of a sudden we take the joint through range of motion. So now we're going to take the joint through range of motion. And as we're taking the joint through range of motion, we're putting pressure on the mechanoreceptors, the receptors that measure mechanical change or pressure, right? And now as we move through that and we get that mechanoreceptor going, now we're getting input into the brain. And then we get to the end of that range of that passive range of motion and we add that small little thrust. Now we're really firing that mechanoreceptor. And if we fire it on the left side, it's different than if we fire it on the right side. If we fire it close to the brain, it's different than if we fire it further down from the brain. It's different if the amount of intensity that's coming from the wrist is different than the amount of intensity coming from the shoulder or the elbow or the shoulder or in the spine itself. So you say, well, you just did the same thing over and over and over. Well, kinda, but not exactly, because C1 on the right versus C2 on the right versus C4 on the right versus C7 on the right is different. And it looks to you, if you're sitting in a chair watching an adjustment, it looks different. I mean, it looks the same, but it's not exactly the same. And that's kind of what it says right here. The findings of the study demonstrate how stimuli to the mechanoreceptors are processed in the brain. Brain processing after adjustments may lead to physiological relaxation via a decrease in sympathetic nerve activity. That's a crucial point right there. Brain processing after an adjustment may lead to relaxation via decreased sympathetic nerve activity. Salivary amylase levels decrease significantly after an adjustment. What does that mean? You could go back up to the top. They measured this salivary amylase, which is meaning suppression of the sympathetic nervous system. Decrease in salivary amylase levels mean there was a suppression of sympathetic nerve activity. So those two things match. Salivary amylase levels decrease significantly, meaning that the adjustment decreased the sympathetic nervous system. And I told you guys about me being in the physiology lab at Parker College and having all those leads hooked up to me. And the results was a parasympathetic stimulation after an adjustment. It was like, yes, my rest and recover nervous system increased after the adjustment. And that's exactly what this is saying right here. Brain processing after the adjustment may lead to physiological relaxation. Salivary amylase levels decreased after the adjustment. But It wasn't just in the brain, it was also in the cerebellum. Because the cerebellum vermis receives somatic sensory information, movement, sensory information. That 3 trillion bits of information that's going into your brain is also being processed in your cerebellum right there. From the spinal cord and via the vestibulospinal tract or reticular nuclei of the brainstem through the spinal cord. The spinal cord is connected to the cerebellum and the cortex and the limbic system, and it's firing all through there, and you get adjusted, and it changes the entire thing together. The cerebellum vermis is activated during mental recall of emotional personal episodes in humans. We talk about physical, chemical, and mental emotional stress. All 3 of those things together, combined, physical, chemical, and mental emotional stress combined, causes the subluxation, causes the state less than light. Right? Okay. Your cerebellum is activated during mental recall. Mental recall. Just sit. Don't move. Just sit right in your chair where you are right now. If you're driving, be careful. But just sit right here and remember something that was emotional. Recall emotional personal episodes that you had in your lifetime. You don't have to move. You don't have to get hit with a bat. You don't have to get tackled. You don't have to fall down. You don't have to do anything but just think of the mental emotional stresses that you've had in your lifetime, and you'll change the physiology of your brain and your body. If you can't adapt, because it'll be an alarm, you'll have the alarm, and then you'll try to adapt. If you keep firing that mental process over and over and over again, you'll lose the ability to adapt, and then you'll become fatigued, which will lead to sickness, which will lead to death, right? Our assessment of body responses in the study showed relaxation of muscle tension and decreased salivary amylase levels phenomenon that are associated with reduced sympathetic nerve activity. It's a key point. You're decreasing your fight or flight response, and you're increasing your rest and recovery response. Here's another highlighted bullet point. Improvement of range of motion. Improvement of the range of joint movement is what it says. Improvement of the range of joint movement. Increasing joint movement increases firing into the brain. Decreasing joint movement decreases firing into the brain. Remember what I said a while ago about my dad and chronic low back pain and all that stuff and all the things that it does, and his spine didn't work and therefore his brain didn't work? Yes, that's what I mean. The ankylosing spondylitis locked his spine down where it didn't have any movement, and decreased range of motion caused decreased firing into his brain, which caused changes in neuronal patterns inside of his brain, changes in mitochondria, changes in activity, changes in right side, left side inhibition, left side, right side inhibition, increased sympathetic response, like muscle tone, like that was tight. All of those things were happening because of his decreased range of motion. It's like motion is life. When people say movement is life, it's not a joke. It's a serious statement. Spinal movement, your brain is connected to every single part of your body. And when your body is not moving, your brain is losing data from that segment. So a decreased wrist, a decreased elbow, a decreased shoulder, a decreased knee, decreased range of motion in the hip is all affecting the brain. That's right there. So what happened after the adjustment? After the adjustment, we had improvement in the range of joint motion. So now once we get the joint moving, now go exercise. Now go for your walk. Now go out there and live your life. And what are you doing? You're taking that range of motion, taking that joint through full range of motion now instead of through half range of motion. And what if you're looking at range of motion on either side? So if my right index finger goes through full range of motion and my left index finger goes through half range of motion, and I do that 1,000,000 times, remember, My right hand is firing into my left brain. My left hand is firing into my right brain. So if I've got increased range of motion in my right finger, but decreased range of motion in my left finger, doesn't it make sense that my right side and my left side would be receiving different amounts of information? And that information that it's receiving is like an alternator to your battery that's charging it up. So it does affect things. In summary, we observed metabolic changes in the brain and skeletal muscle, as well as reduction in subjective pain, muscle tension, and salivary amylase after the adjustment. That's what they did. Okay, if I got just a second, I've only got like 2.5 minutes left, but there were a couple of things I highlighted. It basically goes over the same article. It's just alternative therapies in health medicine. So it's cerebral metabolic changes in men after chiropractic spinal manipulation adjustment for neck pain. This was November to December 2011, and it's got these same people at the same university. So it's the same study, they just have a little bit different sentences. For over 100 years, chiropractors have asserted that overall health can be improved through spinal manipulative therapy adjustments. Spinal dysfunction affects the autonomic nervous system. If you've got decreased range of motion of your neck, if you can't take your neck through full ranges of motion, you and I both, either one of us, you're going to have a change in the autonomic nervous system. That's one of the things I highlighted. And they went through a lot of this. Another one was mental stress causes sympathetic activation, right? Mental stress. And stress-related disorders are frequently accompanied by increased sympathetic activity and muscle tone. Your muscles are tighter. So sometimes I'll put my hands on someone's shoulder after an adjustment, and I'm like, man, this is too tight. Your body is too tight. There's too much muscle tone. We've got to calm that muscle tone down. Chronic activation of the sympathetic nervous system facilitates chronic, tonic, and painful muscle contraction. Your muscles are going to be tight. How do your muscles get tight? Your nerves tell them to get tight. Why are your nerves firing? Because you're fighting and flighting all the time. And that is working together. These authors argue that cerebellum vermis inhibition, decreased sympathetic tone, decreased muscle tone, and decreased pain are all neurophysiologically interrelated and initiated by chiropractic spinal manipulation. I'm going to run out of time tonight, and there's a great little part of this in the comments. So what we might do is just pick it up, because we're going to run out of time, but I'll leave this open for Monday, and we'll just start off before we get to taking health to church, and we'll just kick that in right there on Monday, because that's all we got for you tonight. I hope that was helpful. I hope you guys enjoy that. You guys have a great weekend. We'll be back on Monday at 6. If I can help you, please let me know. You guys have a great weekend.